for this month. So Chelsea Limn is a student at UMass, also in her fourth year, who completed her undergraduate degree in philosophy and biology at Dartmouth prior to starting medical school. She's originally from Colorado, and during her medical school time, she has worked primarily with Dr. Johnson at UMass, where she's been studying meningioma. So she'll be talking today about some of that work, including guidelines for radiographic surveillance of meningiomas based on the WHO grading system.
Thank you very much for that introduction. I will bring up my slides now. Good morning, everyone. My name is Chelsea Limn. I'm a sub-I coming out of UMass, like Dr. Morgenstern said, and I'll be presenting my research on the radiological surveillance of meningiomas based on WHO grading and establishing related recommendations and guidelines from a meta-analysis that we performed of the literature. So this project was conducted in collaboration and with the support of several of our UMass residents and the chair of our department, Dr. Mark Damone Johnson. So to give some background, meningioma remains the most common intracranial tumor. 39% of all intracranial tumors are consist of meningiomas, and of the non-malignant tumors, they comprise 55.4%. WHO grade remains the predominant system by which we classify these tumors, which assigns grade based on histological features to predict clinical behavior of these tumors. So based on documented meningiomas from a large cohort of their WHO grade 1 tumors comprise 80% of these of the overall meningioma tumors. 18.3 are atypical WHO grade 2 tumors, and 1.5 comprise a small portion that are the malignant WHO grade 3 tumors. The 10-year relative survival of non-malignant meningiomas is reported to be 83.4%, while that of malignant meningioma is lower at 60%. We all know the primary treatment for meningioma to be surgical resection with radiological follow-up and or radiation, depending on WHO grade. So one of the primary challenges in the management of meningiomas, especially postoperatively, is predicting whether patients who have undergone resection are likely to experience recurrence and would therefore benefit from adjuvant treatment or closer follow-up. WHO grade and the extent of resection that is also graded on the Simpson grade, which comprises 5 different categories, remain the predominant grading systems by which these tumors are evaluated, as they have been found to be associated with recurrence. However, we've found that these grading systems are imperfect, as several studies have highlighted that the degree of heterogeneity and recurrence-free survival in clinical course within these tumors of the same grade exists. And so even in a case of a patient who has a low-grade WHO grade 1 tumor that underwent gross total resection, we may be surprised by the actual aggressiveness of the tumor and its early recurrence compared to our expectations. So histopathology can be unreliable in predicting tumor behavior, and some cite this to be due to incomplete tumor sampling, inter-observer variability on the pathology side, and the ambiguous histological features that may exist. So postoperative management commonly involves prolonged radiological observation of these patients to detect recurrence or expansion of residual disease, and that practice is predominantly guided at this point by clinical experience and the surgeon's clinical judgment to determine how often interval scans are obtained. And this is due to the fact that there are no current recommended guidelines for the frequency and the duration of radiological follow-up for these meningiomas. So we performed a basic literature search. This is a schematic to show how that was conducted on PubMed with certain search terms like meningioma pathology, recurrence and diagnosis, and human studies. We started at a quite large number of studies that ultimately resulted in 8 studies that fulfilled our inclusion criteria. So I will go on to talk about kind of what that data looked like. So a total of 2,090 meningiomas were extracted across these 8 studies. And these were studies that that included multiple tumors of various WHO classifications. And these studies were conducted across various institutions across countries, so including the US, Germany, Norway, Canada, and Taiwan. Another characteristic of these studies is that all the tumors that were evaluated underwent surgical resection. However, this was to varying degrees of Simpson grades. And further detailed analysis accounting for reliable clinical follow-up and available data. Once we obtained the studies, the patient population that fulfilled those criteria, we ended up with 1,519 patients. And these are the tumors that were analyzed for progression-free survival. So this basically shows how we went about taking all this data and compositely plotting these Kaplan-Meier curves. And the three figures that you see in front of you now are Kaplan-Meier curves from the different studies included in this analysis. So as far as what we found, WHO grade 1 meningiomas were analyzed in 7 of the 8 studies. 4 of the 7 studies included only completely resected tumors. Throughout all 7 studies, more than 50% of patients were recurrence-free by the end of their individual study timelines, and was found to have an average 5-year recurrence risk of 15.9% and an average 10-year recurrence risk of 31.9%. For WHO grade 2 meningiomas that were analyzed across 8 studies, they demonstrated a variable recurrence-free survival rate with a median survival measuring about 36 to 120 months. The average 5-year recurrence risk was calculated to be about 40.9%, and the average 10-year recurrence risk was 62.2%. 4 studies were included in the analysis of WHO grade 3 meningiomas, and as expected, they had the worst overall recurrence rates in comparison to the other 2 grades, with median survival ranges ranging from 18 to 48 months. The 5-year recurrence risk for that particular grade was found to be 73.3%, and the 10-year recurrence risk was calculated to be 86.4%. So this figure shows a composite Kaplan-Meier curve from the aforementioned studies. Log rank testing was performed, and this revealed that among the 8 survival curves analyzing WHO grade meningiomas, these were we could only find this to be statistically significant, whereas it was not found to be statistically significant for WHO grade 2 and 3. So in an additional sub-analysis, these tumors were subdivided into studies that with gross total resection versus studies that included gross total and subtotal resections to determine if Simpson grade also played a significant role in recurrence risk. And our analysis showed that statistical significance was found for grade 1 and 2 meningiomas when accounting for gross total resection alone versus the combined studies. And you can clearly see that there's a observable divergence in clinical course based on the fact that these curves don't overlap. As compared to for WHO grade 3, this was found to be not statistically significant, and that recurrence occurred early regardless of the extent of resection. So as far as the recommendations that we were able to pull from this compiled data, we've determined that strong recommendations for the maximal duration for follow-up imaging cannot be drawn from this. This in part was due to the fact that the risk of recurrence kind of continues beyond the observational period of several of these studies, and may fail to capture significant risk at remote time points from initial time to resection. Because even after 150 months, WHO grade 1 meningiomas in studies such as Olar et al. Demonstrated like a steady decline in progression-free survival, despite other studies showing earlier plateauing around 100 months. So the one aspect in which we did give more recommendations and guidelines was pertaining to the frequency and the interval for post-operative imaging. We know that routine follow-up after resection is important in the management of meningiomas to trend this tumor behavior. So after obtaining the baseline MRI post-operatively at 24 to 48 hours and determining the extent of resection, we recommend radiological follow-up with MRI obtained every 2 to 5 years for grade 1 meningiomas. If stable imaging is obtained for 10 years without signs of recurrence, then the surgeon can determine whether or not to defer any further imaging. If recurrence is observed within those 10 years, then we recommend that the interval of MRIs be obtained every 2 to 5 years indefinitely. And so for WHO grade 2 and 3, regardless of the extent of resection, we recommend that for grade 2, yearly MRIs are obtained indefinitely, and for grade 3, MRIs should be obtained more frequently at 6 months indefinitely. So establishing guidelines are significant for several reasons. Obtaining imaging more frequently than is theoretically necessary for benign meningiomas that are highly unlikely to recur possess significant cost to the patient, financially and otherwise, and may be very challenging for patients who already face an issue with access to medicine and coming back for recurrent follow-up. Additionally, such frequent imaging may prove to be a suboptimal model for resource allocation for hospital systems and insurance companies. And additionally, having evidence-based recommendations may provide assurance to patients when discussing the likelihood of recurrence of tumors that are likely to take a more indolent course. And additionally, clinical burden may also be alleviated to some degree by such guidelines that may support triaging outpatient follow-up by our genuine concern for recurrence. So there are several limitations from this study to note. First, we cannot directly compare gross totally resected tumors to subtotal resections, as several of these papers failed to separate those out and parse that difference. Additionally, we cannot parse out whether these tumors are radiated or non-radiated tumors very consistently. And I think it's also worth discussing that recurrence in these papers across the board were defined as radiological demonstration of recurrence after a gross total resection or progression of the tumor after subtotal resection. And I think the point was to detect whether or not the tumor had recurred at all, but it is not descriptive of the degree of recurrence, so it can't really capture the rate of the tumor growth itself. And so we know that radiologically observable recurrence does not equate to whether or not this tumor would warrant any further intervention on the surgical side. So looking to the future, research efforts are actively in progress to develop a more accurate system that can better predict tumor behavior and prognostication. So there are molecular profiling of other cancers like gliomas have improved diagnosis and treatment of cancers, and several studies have demonstrated that meningioma might also benefit from such evaluation. And this was kind of prompted by a study that showed that loss of function NF2 has been found to arise in half of sporadic meningiomas and most higher grade tumors. So the studies included in this analysis have identified several independent risk factors for recurrence and proposed molecular classification systems that look at things like copy number variation, mitotic index, DNA somatic point mutations, and methylation patterns. And so they also find that this can lead to a more refined classification scheme that is at times more reliable than WHO grade alone in determining tumor behavior. One thing to consider with having such an advanced schematic for classification is that many community-based institutions don't have access to extensive DNA and RNA sequencing or methylation profiling. So that's something to consider. And on the horizon, when it comes to stratifying risk, one thing that I found very interesting in the literature that wasn't part of our study was to look at tumor location, as it has been implicated as an independent risk factor itself for recurrence. And there are also some studies that have found that there are actually certain genetic alterations that are associated with tumor location as well. So looking to the future, I think you can expect development of a very advanced prognostic schema that will be able to predict tumor behavior and the likelihood of recurrence more accurately. And there's a lot of discussion currently about the use and the utility of AI technology in medicine. And I think this is one particular field that could be very efficacious in that it has the ability to perform very high order processing and take into consider various tumor characteristics. And I think this is exciting things on the horizon for this field. So I want to just conclude my presentation to say thank you to all the wonderful faculty, residents, and staff here at Mount Sinai for an incredibly memorable and educational month. I am very fortunate to have been able to witness the practices here of all of the wonderful neurosurgeons at Sinai and get to observe the kind of cutting edge, fascinating trials and research that are being performed here. So I'm open to taking questions at this time. Thank you.
Chelsea, thank you. This is a nice sort of overview of how one puts guidelines together. How would you imagine going about sort of the next step in devising guidelines that incorporate some novel meningioma research and molecular and epigenetic understanding of the disease?
Yeah, I think first and foremost, just trying to do this analysis myself, that it would require kind of multidisciplinary work in engaging kind of the neuroscientists and also statisticians, quite frankly, in doing this kind of multifactorial analysis. And so I think part of the issue comes in the fact that, there are so many disparate studies that are out there that give really good information and data about recurrence and but it's hard from my experience to kind of put those together because they don't often they sometimes differ in how they kind of uh, in how they present that data. And so even performing this kind of meta-analysis, it was kind of hard to tease out, like I was saying, what was gross totally resected. And so just standardizing a little bit of how we report the data and how we have access to that information might be helpful in that endeavor. But again, I think AI technology can really help with that in doing some of those calculations on that level. And there's a lot of research. I think there was a paper that I just read a couple of weeks ago that was published earlier this year in JNS that was looking at tumor location and things like that. So I think we all clinically have a sense of what we think is a recurrent, like a tumor that is likely to recur. And I think a lot of tumor surgeons have that sense. It's just a matter of taking all those disparate characteristics that they have in their minds and kind of putting into a systematic and comprehensive way that can inform guidelines.
Yeah, I mean, I think you're right in that you need to be thinking about the risk of recurrence and the expected timing of recurrence. But the other piece in this that is also very difficult to study, but important to study is cost effectiveness of screening. How much does it really cost to get an MRI every 2 months on a patient, which a number of neuro-oncologists will order for certain diseases. What is the dollar cost, and also what is the social emotional cost, and weight on the family of those repeated screening follow-ups. Do we have any other questions? All right, thank you, Chelsea. Thank you, everyone. This has been a great month for the sub-Is. We have uh, more who just started yesterday, who I'll take a moment to introduce to everybody next week. We're going to move on to our next speaker. So we have, well known to everybody, Dr. Shoira, who